Yeah, so I'm Ryan. I'm one of the PGY4s here at UBC, and I'll be talking about rural surgical care, giving a BC and Canadian perspective. So I have no financial disclosures, fortunately, unfortunately. And so these are just little learning objectives that were forwarded to everyone. So we're going to be looking at exploring unique challenges and barriers faced by patients living in rural settings, identifying economic impact and initiatives to alleviate disparities faced by these patients, and then also discuss potential solutions at the government, health authority, and patient levels. So I thought I would start off this talk with the classic riddle. So if a tree falls in the forest and nobody hears it, does it make a sound? Because I think the root of this riddle comes down to isolation. And so, relevant to this talk, I want to pose the question, are rural and remote patients at a disadvantage when it comes to healthcare delivery? And I think that absolutely they are. So I prepared a case that we'll visit again later on in this talk. This is a case of Mr. Jack Lumber. I just want to take a moment to look at the image that ChatGPT has synthesized. It's completely a fictional case, but I think AI image generation has come so far, even just in the past year. It's pretty scary stuff. But anyways, back to the case. This is quite a common case I'm sure many are familiar with in terms of its concept. So Mr. Lumber is a 68-year-old gentleman from Fort St. John. He is currently retired, but previously worked as a logging truck driver. He presented initially with intermittent gross hematuria, and he had a 50-pack year smoking history. So he was referred by his family physician in Fort St. John to Urology in Prince George for assessment. He was seen in December for cystoscopy, which demonstrated a 3 centimeter papillary tumor. He was brought back for resection 2 weeks later, and pathology at that time demonstrated a muscle invasive bladder cancer. Staging was negative, it was non metastatic. Being the spry 68-year-old gentleman that he is, he opted for a cystectomy and was interested in getting a neobladder. So then he was referred to VGH for this procedure. So this happened 5 weeks later. He does amazingly well. He's discharged home post-operative day 5, and then he drives home back to Fort St. John. The usual post-operative cystogram and catheter removal plans were arranged, and they were supposed to happen in Prince George. So then he does well for a couple days. He's been doing pretty well with his flushes, and then all of a sudden on post-operative day 10, he calls his urologist in Prince George saying that his catheters are both blocked. He's unable to get anywhere with troubleshooting at home. And so instead of futzing around with the emergency department locally, his urologist recommended that he present to UHNBC for a urology consult, given that there's no urology coverage in Fort St. John. So simple enough, but keep in mind that now it's probably late January, early February. And so the road to Prince George from Fort St. John looks kind of like what you see on the left side. The total whiteout, the road conditions are terrible. There's a snowstorm right above Pine Pass, which he must pass on the way down to Prince George. So this kind of situation is not outside the realm of possibilities that a rural patient can encounter as part of his post-operative care. I think it'll be first good to define what it means to be rural. So as you can see, the definition of rural is rather inconsistent. Um, Even within the same year, Statistics Canada had, despite their best efforts, outlined two different definitions of rural. The first one identifies objective measures of ruralness with population and density. And then the second measure basically says that, anything that's not urban is rural. Anything that we're not including as an urban population center is rural by definition. So fortunately, there's a more standardized definition of rural and one that's fortunately applicable to us specifically in BC. It's from the Rural Practice Subsidiary Agreement, or the RSA for short. So between the BC government, Doctors of BC, and Medical Services Commission, it's an agreement made that outlines resource allocation and remuneration for physicians. It's based on the seven following factors, including number of physicians and specialists within a certain radius, population, proximity to other major medical communities, um, and then it's given a point-based designation from A to D, with A being the most rural. Essentially, it's a measure of how medically isolated a community is. There's a lot of policy that rides on this definition. In addition to the resource allocation and remuneration, there's also medical education and travel assistance for patients, all kind of rely on this RSA designation. And you'll see it does come up again and again later on in this talk. So looking at Canada, approximately 18% of Canadians live in rural areas, corresponding to about 6.6 million people. So this is using 2021 census data. And interestingly, BC comes in as having the lowest proportion of rurally located citizens at about at 12.7%. And this is in comparison to PEI Nunavut, both of which have about 54% of their population living rurally. Only about 8% of physicians in the country work in a rural setting. And this includes family physicians, medical and surgical specialists. 2.2% of medical and surgical specialists work in a rural setting across the country, and this lines up well with the numbers in BC, which is about 2% as well. However, in the last 30 years or so, the number of surgical specialists that were located in rural settings has actually been declining. And so this has actually led to the closure of half of the small volume surgical programs in the province. The topic of caring for rurally located patients is relevant to all specialists, given that rural and remote communities exist in all health regions and health authorities. The travel to and from these rural communities can be costly, time-consuming, potentially treacherous, as we saw with Mr. Lumber, and stressful. And as I'll show you soon, this problem is actually amplified in urologic care in BC, given the distribution of urologists in the province. To make matters even worse, rurally located people, on average, they're also the least equipped to handle the travel, given that they're often older, of lower socioeconomic status, and often sicker. So this is just a map of the population density in Canada with the distribution of the rural communities. Most obvious is the aggregation of population close to the border, especially in BC and Ontario, where you'd expect. And then so next we have a closer look at BC, again demonstrating what we already know with population concentrating around Vancouver, Kelowna, Kamloops, even an aggregation in Prince George. So this figure took a very long time to make. So please excuse any errors that may have made its way into its design. But here, basically, we have everything that they call a hospital in BC. And this is after filtering out health units and medical clinics. Next, we have all of the hospitals that are considered rural based on their RSA designations. So we've grayed out the urban areas. The next map shows rural hospitals that are capable of providing surgical services. And to narrow down even further, and I think this is kind of what we're most interested in as urologists, this is the distribution of rural hospitals that have some form of urology coverage, whether it's surgical or simply an outreach clinic. And then finally, this is a map that demonstrates where local urologists are, or where urologists are located. And so there's in-house urology coverage, and often these areas become the referral centers from adjacent sites too. So looking at those maps, it's quite clear that accessing urology care in BC is harder for patients than, say, general surgery or orthopedic surgery, given the distribution of urologists across the province. So things that we currently use to bridge the gap include telehealth appointments, visiting clinics, including subspecialty clinics such as the PEDS traveling clinic, flying visiting urologists to regional hospitals to perform surgeries, leaning on our general surgery colleagues and family physician colleagues to perform some basic urologic procedures, And so we also know about an example of a general surgeon in Whitehorse who performs cystoscopy and stent removals for patients post-ureteroscopy, for example. And finally, utilizing subspecialty trained urologists in urban centers for complex surgeries and complex consultations. So it seems like the availability of surgical care in BC is actually in jeopardy. At least that's the picture that's been painted by these Work BC reports. Currently, there's just under 1,600 surgical specialists in BC, with about a fifth of them in rural regions. Half of these are supposed to retire by 2034. Looking into general surgery numbers, in this Huang et al. Paper published just last year, they looked at stats from 2022. There were the equivalent of 197 full-time general surgeons in BC. But if you compare that to the national average based on population, BC's quota should have been 302 general surgeons, 302 FTEs of general surgery. And so we're about 50% short of the benchmark. Um, there are about there are 830 expected job openings for surgical specialists within the next 10 years. So that's kind of all comers surgical, um, all the different types of specialties. Um, and so this is just according to the BC Labor Market Outlook report. Strangely, UBC only has 35 to 40 surgical residency spots per year. So going at this rate, it's going to be a shortfall of about 500 surgeons by 2034. If we're assuming just organic growth within our own ranks, of course. So take these numbers with a grain of salt, because there would need to be significant capital investment nonetheless by hospitals to provide the adequate resources for these 830 additional surgeons. So I think the 830 number itself is out of reach. But these numbers are also assuming that no growth is being made by surgeons coming into the province. But kind of for argument's sake, I said that the number of surgeons coming in and leaving the province are approximately equal. So that part is a bit of a wash. So I'm sure many of you know about the Enhanced Obstetrical and Surgical Skills Program being offered across the country. These are family physicians who are undergoing additional year of training to pick up skills in surgical obstetrics and minor general surgical procedures. Several programs are offering this training, with the enhanced surgical skills only being available in Saskatchewan. It was developed as a program in the late 90s to address shortages in rural settings, mostly for obstetrical care. And then trainees who are graduating from these programs can expect to be able to perform C-sections, DNCs, fourth degree tear repairs. And then with the enhanced surgical skills program, certain minor surgeries such as hernia, um, vasectomies, appendectomies, and scopes could all kind of be within their reach. Interestingly, the enhanced surgical skills certification is not actually required for family physicians to be able to provide basic surgical procedures. A classic example of this would be South African trained physicians practicing in northern BC, who themselves have significant surgical exposure from their internships back home. And they're able to perform these minor procedures quite comfortably. And I saw examples of these when I went on my third year med school family practice rotations. There was a paper published by the General Surgery Group in Vancouver. Dr. Yosh, I believe, is on as the PI for this. Looking at general surgical coverage in rural BC, taking into account both FRC trained general surgeons as well as family physicians with this extra surgical skills certification. They reviewed data from 2022, 2023, sorting out for communities with a population between 1,000 and 25,000. There were 45 such communities. 17 of these had these family physicians who had this enhanced surgical skills certification, with or without specialist surgeons. I actually think there's 5 communities that don't have any general surgeons present, but only ESS providers. So that'd be Smithers, Vanderhoof, Revelstoke, Creston, and Fernie, the orange only dots on the map. And then 5 communities had specialists only. Um, And so this made up so 23 communities had absolutely no surgical coverage, making up about 53% of the communities, unfortunately. So they found that there were 32 family physicians with these enhanced surgical skills in the province of BC, making up about one third of all of that workforce in Canada. Um, and so they then looked at the billing code to see what kind of procedures were being performed. As expected, colonoscopies and C-sections were the most common procedures being performed, being kind of the goal of setting up this program. But interestingly, vasectomies were the third most common procedure, putting urology on the map. Um, their discussion highlighted some interesting upcoming directions for ongoing surgical care in BC. Contrary to other papers that I saw in the early days of the ESS programs developing, this paper called for ongoing collaboration between family physicians and specialist surgeons in these settings, and validating the expertise of these providers. However, they also called for longitudinal training and continuing professional development initiatives, given the relatively low volume of procedures seen at these sites, in order to maintain skills for these family physicians. Finally, they called for prioritization of retention and recruitment to prevent professional isolation, which is a known risk factor for complete abandonment of surgical services in these small communities. The government already has several incentives that exist for rural specialists in BC. Most of these incentives are financial, including annual rural retention bonuses and premiums on billings performed in rural settings. There's also ample funding for rural CME, as well as subsidizing locum payouts. There's incentives geared towards anesthesiologists as well, which can help with increasing access to the OR. However, there's ongoing challenges that I think are rather unique to specialist surgeons. First off, being infrastructure. So due to the procedural nature of our jobs, infrastructure is of utmost importance to allow procedures to go ahead and for new services to be brought into these locations. So of course, this introduces a large upfront capital cost. And then speaking for new surgeons coming into these settings, professional isolation is particularly difficult for surgeons who benefit from surgical assists, mentorship, share and call coverage, all as kind of protective factors from physician burnout, and to be able to provide adequate care. So this is again to highlight that surgery cannot exist in a vacuum. In order to support surgical services and community infrastructure, such as OR space, beds, specialized equipment, and major equipment need to be considered when developing or at least maintaining surgical services in a community. There will need to be coverage by anesthesiology to perform procedures and surgeries, depending on the complexity of the patient. You may also need ICU, interventional radiology, oncology, surgical assist may also be necessary. The ongoing struggle with nursing staff and allied health services, and trying to get adequate coverage for those specialties in rural settings will also undoubtedly hinder rural surgeons. And finally, optimizing time in the OR is a complex interplay of several factors, including resource allocation, staffing, efficiency, and equipment quality. Perhaps more pertinent to rural physicians, one might expect to have a higher proportion of missed or delayed appointments, just due to the very nature of patients having to arrive at the hospital from far off locations and possibly in bad weather. So there are several barriers for patients which exist, which can be grouped largely into geographic, financial, and psychosocial barriers. I think I'd be amiss in talking about rural patients if I didn't consider emergency and acute patient transfers. By the very nature of living remotely or coming from regional hospitals or health centers, there would be a delay in obtaining definitive care from a tertiary center. We all know how quickly a patient could decompensate with, a septic stone, urosepsis, and so distance and therefore time is playing a large role in how well the patient is when they arrive on the doorstep of St. Paul's or on the doorstep of VGH. So I tried looking at the stats for how much is spent provincially on acute patient transfers from rural settings, but unfortunately, that data is not publicly available. So then I thought to extrapolate a bit from what BC Ambulance charges non-MSP covered patients, and the costs quickly add up as you can see. And even with these numbers, it's likely an underestimation, as I would expect. A large portion of this cost is being subsidized by the government and by BC Ambulance. And then, to further add salt to the wound for these acute transfers, for many of these patients, I've had many patients who express disappointment when they find out that upon their discharge, they have to pay for their own transportation to go home, make their own arrangements. But unfortunately, this is just adding a financial burden to the patient. Whether or not it's right to have the system pay for their return is up for debate. So then looking at the patient experience, there's this report put out by the Center for Rural Health Research looking at the out-of-pocket costs for rural residents when they're traveling for healthcare. There were 381 rural patients surveyed over the span of about 6 months. The costs associated with healthcare was looked at in terms of how much costs were incurred for leaving their home community and going to a tertiary center. Most respondents were from interior Northern Health Authority areas, making up about 70% of the respondents. And interestingly, the highest costs were incurred by patients from Vancouver Coastal Health Authority, but keeping in mind that Vancouver Coastal actually extends upwards into the coast. So these are patients from the Haida Gwaii area in the Central Coast region that experience these very high out-of-pocket costs to get to the hospital. The average distance traveled by these patients was just under 2,000 kilometers. And so you can see that the out-of-pocket costs are quite substantial for these hospital stays and for these out-of-town visits. Upwards of $2,000 was the average out-of-pocket costs. A large proportion of these were made up of transportation and accommodation costs. This seems like this was particularly stressful for patients, with 59% of respondents thinking that this directly impacted their health, and it was the traveling itself that had impacted them. And then, this pushed a lot of people into financial hardship. 78% who reported difficulty paying the cost for accessing healthcare outside of their community, just due to the associated costs. And then, only 14% of the patients reported receiving financial assistance from some organization or the government as reimbursement for their out-of-pocket costs. Later on, we'll discuss the travel assistance program, which is an initiative by the government to try to help alleviate some of this burden. And so these are just some anecdotes from the people that were interviewed by this group. And so the themes that are kind of coming up are very dangerous travel, expectant mothers who are having to leave their home communities to deliver their babies, people who are having to uproot their families in order to attend medical appointments or get diagnostic procedures, people who have to delay healthcare in order to make time for these like several day ordeals for some of these people. And then, also living in these areas where, you have shortage of surgical services or specialist services in these home communities. And so, you're kind of left without very many options. You're left kind of feeling helpless. So the themes I'm trying to get at are, these are real emotions being felt and real experiences being expressed by people who are rurally located and having to seek healthcare far away from home, right? So danger, feeling alone, feeling helpless, feeling like they're a burden to their family and their communities, and having to delay healthcare in order to, you know, in order to take care of things at home and take care of daily duties. So as for whether this truly affects health outcomes, it's hard to say. There's kind of varying reports looking across multiple surgical services. These are people who have undergone, lung resections or a pediatric surgery or arthroplasty. Um, and so these studies are kind of looking at a broad range of surgical subspecialties. So whether or not it actually affects post-surgical outcomes is not completely clear, but the evidence is kind of shifting or convincing towards the yes side. And so all of these 8 metrics were used across these papers to as a proxy for post-surgical outcomes, ER visits, readmission, with most of these saying that there is an effect with people having negative outcomes as a result of the distance that they have to travel. Some of the confounders, obviously, is that as we said earlier, rurally located patients often have poorer baseline health, poorer health habits, as well as poorer health literacy. And so that can also contribute to poorer outcomes, especially in the post-operative setting where, there's a lot of body changes that they have to get used to and a lot of post-operative care that's often quite intensive. As well, going back to the previous theme of, what is the definition of rural? The radiuses or what they define rural in these papers were also heterogeneous. So now we're just looking at some of the policy and advocacy initiatives taken on by the government and independent groups. These are just some examples of ways that we're trying to help alleviate some of the stress on rural patients. So the Rural Coordination Center of BC, RCC BC, they're a network of rural healthcare providers, oftentimes non-surgical, administrators, community members, researchers, and they serve all RSA communities. So it really is kind of like a multidisciplinary group with various key stakeholders. They coordinate connections, rural health research, and the Rural Health Conference that happens every year. Projects and learning opportunities, enhancing skills, and also advocacy at the government level to look into more resource, more funding, and optimization for rurally located patients. So actively, there's 29 rural and global health initiatives. Again, most of these are focused on non-surgical initiatives, except for the Rural and Surgical Obstetrics Network initiative that RCCBC has put on. So it's a $20 million initiative designed to address initially rural maternity services attrition. So the loss of obstetrics providers in these communities, again, leading to mothers having to leave their hometowns, leave their support networks, leave their families to deliver elsewhere. So this was set up as a way to try to prevent that. Their main objective is to support those family physicians who are providing these additional skills, whether it's surgical skills or obstetric specific skills, and for them, I think they would also be a good target for ongoing skills development and optimizing infrastructure in these smaller communities, at least to be able to provide care for these smaller procedures. So this is an initiative that's more focused towards physicians. And so this is the Northern and Isolation Travel Assistance Outreach Program. It's a funding source that's provided to health authorities to compensate for physicians who are providing outreach services to RSA communities, such as Prince Rupert. They pay you back in terms of reimbursing your accommodation, your travel mode, as well as a fee for your travel time as well. So using, a 4-day visit to Prince Rupert as an example, of course, not taking into account any billings or any, rural bonuses, $480 for hotel, $400 for flights, and then a 6-hour door-to-door round trip travel time, leaves it at about just under $2,000, leaving the government's pocket in order to fund this initiative to move the specialist over. You can make an argument that, okay, well, you have to provide the space, which is part of the program. You have to provide some of the administrative staff as well. So there's additional underlying costs to the program itself. But I think this is a good starting point, at least for comparison's sake. And so I was hoping to compare it to this travel assistance program. This program is actually patient facing. So it assists patients for non-emergency specialist visits away from their home communities. So a checkup visit, you know, having to do diagnostic tests, follow-ups with BC Cancer Agency, in other communities. It's a partnership between Ministry of Health and actually private transportation companies, and it requires a pre-approval. So basically, what happens is the patient's family physician sends off a referral for this patient to be covered under this travel assistance program. The government then approves it and then mails the patient a form, which they use basically as a coupon for when they are booking their transportation to and from their appointments. And that's kind of like the bird's eye view of what's going on. 15 to 100% of the accommodation is covered depending on the mode of transportation. The 100% is usually reserved for BC ferries. 15% and 20 to 30%, that's kind of more reserved for private airlines like Pacific Coastal Air, Central Mountain Air. There's no accommodation assistance, unfortunately. There are medical rates that exist for a list of hotels that the patients can access. So the out-of-pocket cost for a patient leaving Vancouver, or sorry, visiting Vancouver from Prince Rupert, so the opposite of the above example, just for an overnight stay, is approximately $500 out of pocket, $620 for the system as a whole, assuming 30% of the flight is being covered by this TAP program. So then crunching the numbers, looking at the two programs and then the cost to the system as a whole, assuming 80 outpatient clinic visits in each scenario, in a 4-day visit, 80 patients a day, or 80 patients in total, I figured was a reasonable number. The cost of the system, just looking into travel and accommodation, again, is just under $2,000. But if you multiply the cost per patient with the TAP program by 80 visits, you're looking at about $50,000 of cost of the system, whether that's from the patient's pocket or the government's pocket combined. So all this to say, you only need to see about 3 to 5 patients in Prince Rupert as a visiting urologist or as a visiting specialist in order to break even for the system. And so looking at the cost to the government, to the Ministry of Health, so they're covering 30% of the patient's flights. So $120 times 80 visits, just under $10,000. Your break-even point being about 15 to 18 patients. 15 to 18 patients seen over a 4-day course. Well, that's about 4 patients a day. That's something that even I can do. So this all is to say that outreach visits are cost effective for the patient and the system, thanks to this program. But even in the absence of this program, I think that still makes a lot of sense. So then looking ahead into future directions, I think there's kind of four pillars of um, four pillars of change, or four pillars of focus that need to be addressed. At the policy level, involving patients in these advocacy groups, like in the RCC, BC initiatives, um, having these patient advocates and providing support at the programmatic level, all go towards improving the experience for patients who are having to leave their home communities to get healthcare. As we already see with these transportation companies partnering with industries to alleviate some of the strain. I think at least in the oncology world, there's a lot of work being done to try to bring care closer to home for these patients, by providing services, and doing injection teaching to local nurses and local health units. With regards to funding, I think funding can be directed towards infrastructure and equipment, at least to provide the setting to develop surgical services, as well as having new initiatives and further financial support for non-emergency visits, further taking the burden off of these patients, giving them one less thing to worry about, not having to make them choose between their health care and having money in the bank, not putting patients into financial distress for a healthcare appointment. Training and recruitment is also important, with collaborating with residency programs, both at the health authority and the ministry level, to address these impending shortages of surgical specialists. Developing or opening spots with return of services, to kind of direct some of the shortages can also be helpful. Skills training with family practitioners, family physicians, and trainees, I think, can also go a long way. There's certain skills that I think could be in the scope of family physicians eventually. Things like, if someone's in urinary retention, performing needle aspiration and decompression of the bladder, or even putting in a suprapubic catheter in Emerge, all possible. Vasectomies and circumcisions can also be done by family physicians, as we can see. Additionally, general surgeons, especially in some of these far off communities, having them do the odd cystoscopy, or a cystoscopy clot evacuation for a patient with recalcitrant gross hematuria, cystoscopy stent removal, stent insertions, perhaps even for septic stones, rather than having to wait for PTN and in a decompensating patient, undoing a testicular torsion. All these are kind of potential avenues that I think could be within the scope of a general surgeon. And then finally, having sustainable change, addressing gaps in other needed specialties, not having to close operating rooms because of lack of anesthetic coverage or nursing coverage, having IR support so that further surgeries can be performed, like partial nephrectomies, and then also prioritize retention and succession planning as a way to reduce physician burnout, keep physicians in these communities as well. So this is just a list, as complete as I can get it, for outreach communities who or communities who are benefiting from outreach services from BC urologists. This kind of encompasses a lot of different communities across the province. But I think there's still room for more in terms of frequency, or even areas that can be served. Of course, the limiting factor being resource, and also the limited number of urologists in the province, who themselves have busy patient loads and family lives to deal with. So going back to our example case, right? So Mr. Lumber, from Fort St. John, he's supposed to be retired. So over the last 3 winter months, he's had to do 2 visits to UHNBC in Prince George for the initial cysto, the TURBT, He had a cystectomy and VGH, which was a big trip down to Vancouver. He had an acute visit with the blood catheter, and then he also had to come back for the cystogram and catheter removal. 5 trips over the span of 3 winter months, driving back and forth from Fort St. John. So going back to that survey study, looking at the average costs incurred by these patients, the out-of-pocket costs just for a trip down to Vancouver was in the realm of $3,300, and so that includes kind of all of the relevant costs. But you know, extrapolating this, out-of-pocket costs could easily exceed $5,000. Adding on lost wages, having to arrange for child and pet care, perhaps. So quickly adding up for these patients, especially having to undergo surgery. This is, in the realm of 7,500 kilometers in potentially dangerous road conditions, posing itself a health hazard. Tons of time spent traveling with work hours lost, having to cater to flight schedules and cancellations or, ferries being overbooked. And then also just, needing to travel for small things, like unblocking a catheter, or just minor troubleshooting, follow-up care, that kind of thing, all kind of are unique experiences that rurally located patients have to endure, as opposed to someone who's has access to a local surgeon. So this is my homage to my Prince Rupert visit with Dr. Patterson a couple months ago. Um, Great place, beautiful place if you want to visit. The right side is just the view from the clinic window. Well, Dr. Patterson got this room. I didn't get this room. I just got to stare at a wall all day, but it was worth it. And then a special thanks to people who've kind of helped with providing some information, some guidance, and also some inspiration for doing this talk. And I'm happy to take any questions that we might have.